In this video, I'll be answering viewers' questions about MS relapses. If you want to better understand MS attacks and how to treat them, then don't turn away, because that learning starts right now. Howdy! Thanks for learning about MS with me, Aaron Boster. I started this YouTube channel to help my own MS clinic patients learn between visits, and it's my hope that through these videos, I can help you learn too. I adore viewers' questions and comments, and in today's video, I'll be answering selected questions from viewers specifically related to MS attacks. Let's jump in. Question number 1 comes from Cindy, who writes, with a relapse, do you recommend IV steroids or by mouth? Cindy, excellent question, and as it turns out, both are equally effective. The most common way to treat an MS attack is with a gram of IV solumedrol. That's a liquid bag of steroids. They spike a vein and they run the drug into your arm. Most commonly, that's given for 3 to 5 days in a row, but that's not the only option when treating an attack. It's also equally as effective and equally as safe and tolerable to take high-dose oral steroids. Now, they don't make 1,000 milligram pills, and so you end up taking a bunch of pills if you're using prednisone. The important take home here is that it works just as well, and it creates options for people. Some of my patients strongly prefer the IV. Either they find that for them it's better tolerated, or that for them it seems to work better, or the side effects are more favorable. But I have a large group of patients that strongly prefer the pills. They tend to be cheaper, you don't have to go to the infusion center, and there's certainly upsides to swallowing some pills in the morning as opposed to an IV. At the end of the day, it's all about what works best for you, and I strongly encourage you to talk to your neurologist to figure out what's the best option if, God forbid, you need treated for an attack. Awesome question, and thanks for writing in. Our next question comes from Andrea Shoup, who writes, do steroids impact the amount of disability after a relapse? If not, why give steroids given their side effects? Also, how many rounds of high-dose steroids are safe, in a year or in a lifetime? Andrea, outstanding question, and thank you for writing in. Steroids hasten the recovery of a clinical attack. If, God forbid, you've gone blind because of an attack of optic neuritis, and giving you high-dose steroids returns vision, that has major functional benefits, and hastening the recovery makes a world of sense. It's also my personal belief that steroids can quell active ongoing inflammation, which is literally causing brain damage and spinal cord damage. It's my belief that steroids make you better faster, but also preserve more brain function. And given my druthers, I certainly want to treat you with steroids when we identify an attack. Now, of course, you're in charge of you, which means we're going to have a discussion. And at the end of the day, if you say, nuh-uh, I'm not going to make you do something that you're not comfortable with. Your second set of questions about the safety and frequency of steroids is also very relevant. If you require 1 or 2 courses of steroids in a given year, I am very concerned that we do not have good control over your disease. And I think that we have to look critically at the disease-modifying therapy. And this is a situation where we're probably going to want to escalate the DMT. You're asking more specifically about the safety of suppressing the immune system with recurrent pulses of steroids. Giving someone a 5-day course of high-dose steroids doesn't have long-term immunosuppressive effects. And from a safety standpoint, if we're doing that once, twice, 3 times a year, I'm not terribly concerned about chronic immunosuppression. If, however, we're needing to use steroids more frequently than that, I do start to become concerned about chronically suppressing the immune response. I'm not aware of a lifetime concern for too many steroids over a given human's life. I do think that as we use steroids, we have to keep in mind it can elevate blood pressure, it can increase the risk of diabetes or problems with sugar, it can create cushingoid problems, and it can be rough on the bones. And so there's a lot to consider weighing the risks and the benefits of treating an attack. Again, thank you for the awesome question. Our next question comes from viewer Julie Jo Raymond, who writes, why is gestational diabetes a problem with steroids? Julie Jo, when you give someone really high-dose steroids, it can temporarily interfere with their body's ability to process sugar. And if you were to take a healthy person who doesn't have diabetes and doesn't have a history of gestational diabetes and give them high-dose steroids, if you check that person's sugar, you may find that transiently their sugar levels are elevated in their blood. Now, in someone with a normal endocrine system, that doesn't really have any long-term detrimental effects. However, if that person has a history of diabetes, giving them high-dose steroids can really throw their sugars into whack. And when someone has diabetes, we have to partner with their primary care doctor or with their endocrinologist and use sliding scale insulin while we're treating an attack with steroids. Sometimes it's tricky and we actually admit the patient into the hospital. Now, if you have a history of gestational diabetes, that means that during the time around pregnancy, the sugars got out of whack. And this is also a concern when giving that same person steroids years later. When we have a patient who has gestational diabetes or a history of gestational diabetes, and we're going to give them steroids for an attack, again, we partner with the primary care doctor or with an endocrinologist to check their sugars. And if we're finding that they're particularly out of whack, we can use a sliding scale insulin. It's all about patient safety and balancing the beneficial effects of hastening recovery from an attack against the concerns of poor sugar control in the background of diabetes or gestational diabetes. Viewer Becky Barnes writes in, "Hi, Dr. Boster. How often do you see optic neuritis causing permanent blindness in one eye? Is that considered a severe relapse?" Becky, causing blindness in an eye most certainly qualifies as a severe relapse. And in the acute setting, so days to weeks after optic neuritis, sometimes we have patients that have completely lost vision. Fortunately, optic neuritis caused by multiple sclerosis generally has a return of function. I'm not telling you that it's 100%, but most of the time patients regain function. I'll share with you that in my experience, optic neuritis early on in the disease course tends to have a better long-term prognosis for regain of vision as compared to optic neuritis which occurs later in a given person's disease. I also want to point out that optic neuritis caused by MS tends to fare better as compared to optic neuritis from a cousin of MS, neuromyelitis optica. NMO optic neuritis tends to be much more severe with much poorer recovery. Nonetheless, in both cases, we can aggressively treat optic neuritis attacks by using high-dose IV steroids or oral steroids, or when necessary, using plasmapheresis. Great question, Becky. Thanks for asking. Our next question comes from viewer Marilyn Lalone, who writes, "Can an abscessed tooth cause the same MS relapse symptoms that a UTI can cause? I've been feeling pretty punky, and hopefully, now that my tooth extraction is done, I'll be bouncing back." Marilyn, you bring up a most excellent point, a discussion about a pseudo relapse. Pseudo is the Greek word for similar to, but it ain't. And a pseudo relapse is when MS symptoms manifest or come back out in the setting of an infection. The most common example of an infection which could trigger a pseudo relapse is a urinary tract infection. And you are absolutely right that another infection, such as an abscessed tooth, can also cause a pseudo attack. In the setting of a UTI, when we treat the urinary tract infection, we expect the neurological symptoms to subsequently go away. And I would expect the exact same thing in a pseudo attack caused by an abscessed tooth. Excellent question. Our next question comes from one of my most cherished viewers, Britta Roth, who writes, "Good afternoon, Aaron. My question is there a combination between infections like the flu and flare-ups or relapses?" And the answer is yes. During the winter months, when we see more flu, we see an increased risk of attacks. It's rather tricky because a flu could trigger a pseudo attack where you have an infection which raises your core body temperature and causes old neurological symptoms to kind of come back out and visit you. And when the infection goes away and the core body temperature drops back down, those symptoms go away. That's a pseudo attack. But a flu can also trigger an MS attack and cause new neurological symptoms to manifest. And so obviously the importance of seeing your MS provider, having a proper neurological examination, and being tested for infection is key to success. Britta, as always, it's wonderful to hear from you, and thank you for the awesome question. Our next question comes from Jennifer Cruikshank, who writes, "I am scheduled for rotator cuff surgery on Friday. Can surgery cause a relapse? Are there any precautions I should take?" Jennifer, it is possible that the trauma of surgery might trigger an attack, but we have to keep in mind a couple key things. You're not multiple sclerosis. You're a human being who happens to have multiple sclerosis. You also, based on your question, happen to have a rotator cuff tear. And we have to weigh the risk-benefit of having your shoulder fixed so you can use your arm against the slight possibility of an attack. It's generally my opinion that it is worthwhile to proceed with the surgery when it's necessary. If, God forbid, it were to trigger an attack, after healing we can certainly treat it using high-dose steroids. Again, it goes back to the risk-benefit, and sometimes life is a little too generous. I hope that your rotator cuff surgery went well, and I certainly hope that it didn't trigger any MS symptoms. If you're watching this video, share in the comments how things are going. I hope they're going well. Our next few questions have to deal with attacks and the MRI. Paul Zacher writes in, question, how common is it to have a clinical attack without MRI evidence? And the answer is, it's pretty common. If someone comes to my clinic and has manifested new neurological symptoms, and I can see those symptoms on an examination, I don't feel I need an MRI. If I were to get an MRI that didn't show spots, I don't care. They still have an attack. They've still manifested symptoms, and I can still see them on exam. If I see that they have a new spot on their MRI, it doesn't change what I'm about to do, which is to treat the attack. The MRI is not a perfect measure. It doesn't capture all the pathology of MS. And there's lots of different reasons why that's the case. Suffice to say, we're treating the human being, not the MRI. And if someone manifests a clinical attack and has findings on exam, I don't think the MRI is even necessary to be ordered. And if it was ordered and doesn't show new spots, I still think we need to treat the attack. Great question, Paul. Thank you. Nicola asks almost the opposite question. Do you treat active MRI lesions without clinical presentation? My answer is yes, I do. When I see an MRI that shows a newly enhancing lesion, meaning it lights up after giving contrast, that means the same thing to me as if that person manifested a clinical attack. Either one of them, in my opinion, is considered new disease activity, and either one of them deserves steroids to quell inflammation. I have an entire video on this topic, and I'll throw a link up above in case you want to hear more about that. We'll wrap up these viewers' questions with one more question related to the MRI. This question's by Carried M, who writes, finally got an MRI. No new lesions since February of 2015, but some older ones are larger. Is this breakthrough? By my way of thinking, yes it is. If you have a clinical attack, I call that activity. And if you're on a medicine and you have a clinical attack, I call that breakthrough activity. I apply the same logic when looking at the MRI. If you have a new MRI that shows a new spot, I call that activity. And if you're on a disease-modifying therapy and the MRI shows a new spot, I call that breakthrough disease activity. To me, seeing an old MRI spot that's gotten larger is another sign of activity. And if you have a new MRI spot that got larger despite taking a disease-modifying therapy, that's breakthrough disease activity. In my clinic, that's grounds for a discussion on escalating or changing therapy. Thank you for asking that awesome question. If you'd like to learn more about the MRI and multiple sclerosis, check out this playlist right there. YouTube thinks that you would adore this video right there. And if you haven't yet subscribed to my channel, please consider doing so. Just click the circle with my head in it. Go ahead, click my head. My name's Aaron Boster, and thank you for learning about MS with me. Until my next video or live stream, take care.